So I'd like to thank everyone who's joined us remotely and also in the room here. We have folks from BC, Alberta, Ontario, the States, and also New Brunswick. Today we're excited to hear from our speaker, and after that we'll open up the floor for discussion and any questions you might have. So now I'd like to introduce you to Jill Matheson, who will be presenting on the implementation of a survivorship nurse practitioner role in British Columbia. Jill is a survivorship nurse practitioner at the BC Cancer Agency and Fraser Health. Jill has worked in nursing for well over 20 years and as a survivorship nurse practitioner for about 2 with our team. And we're delighted, Jill, that you can be with us today. So I'd like to ask everybody to mute your phones. It sounds like you already have. And I'd also like to remind you that these rounds are being recorded. So I'll hand off the presentation now to Jill, and then we'll come back for a question and answer.
Thank you. So I'm going to start, but I just want to say that I haven't done this before, so some of this might be a little disjointed. However, I'm going to present the implementation of a survivorship nurse practitioner role in BC, and this will be partly about my role and partly about my counterpart, Christina Morrison, in Vancouver. So first I'll talk about the Cancer Agency. The BC Cancer Agency's mandate is to reduce the incidence of cancer, to reduce the mortality rate of people with cancer, and to improve the quality of life with people living with cancer. They do this by through services of prevention, screening, early detection programs, research and education, and care and treatment. The research center departments include the Cancer Control Research, the Center for Lymphoid Cancer, Experimental Therapeutics, Genome Sciences Center, Integrative Oncology, Molecular Oncology, Terry Fox Laboratory, and the Trev and Joyce Dealey Research Center on the island. So the BC Cancer Agency has 6 regional cancer centers. We included this slide just so you could get an idea of where they all are. There's a map inset there. I'm not sure how well people can see this slide, but most of the cancer survivors are centered around in the Lower Mainland, and that's where Christina and I have our roles. So there's 6 regional cancer centers, and in the Lower Mainland there's the Vancouver Center, the Abbotsford Center, Fraser Valley Center where I work. And in the northern one is the little dot that's in the middle. Maybe I can do this. Can I do this? That's the northern BC Cancer Agency Center, and here is the interior one. No, can't do it anymore. So just below that hand and to the right is the Cindy Aluwalia Hawkins Center for Southern Interior in Kelowna, and then there's a center on the tip of Vancouver Island. So the Provincial Survivorship and Primary Care Program, of which Christina and I are a part of, our mission is together with our partners we will provide leadership, invest research and innovation, and build system capacity to support high-quality integrated care and improved experience for all cancer survivors in British Columbia and the Yukon. And our vision is that all survivors and those who care for them are supported and empowered to live their best lives with the cancer and beyond. Here we go. Okay. So we define survivorship as starting at the time of diagnosis. This slide shows the many routes that survivorship takes, depending on the cancer and its response or lack of response to treatment. And who is a cancer survivor? The term cancer survivor has evolved over time. When cancer was considered incurable, survivor described family members who had lost a loved one to cancer. With time, as treatments improved, survivor referred to individuals who remained cancer-free for a minimum of 5 years. And now, the National Coalition for Cancer and Survivorship in the United States defines someone as a cancer survivor from the time of diagnosis and for the balance of their life. And the definition has been expanded to include family members, friends, and caregivers. So the definition of cancer survivor is not without controversy, and I know many of my patients and probably Christina's aren't comfortable with the term. But within the scope of this definition, survivorship includes physical, psychosocial, economic issues of cancer beyond the diagnosis and treatment phases. Survivorship also includes issues related to the ability to get health care and follow-up treatment, late effects of treatment, second cancers, quality of life. Family members, friends, and caregivers are also considered part of the survivorship experience. I think it's actually hard to separate a survivor from their family and friends because they all experience together, each in their own way. Access to timely and comprehensive medical and psychosocial services is vital to health and well-being of the cancer survivors. So, how did the survivorship nurse practitioner role begin? It began with an opportunity. In recognition of the high number of BC residents who do not have primary care providers, the BC Ministry of Health started a campaign to hire nurse practitioners through the regional health authority system to address the primary care needs of vulnerable populations, and the survivors are one of these populations. The BC Cancer Agency researched the attachment rate of people who had a diagnosis of cancer and discovered that a community-based survivorship NP role could benefit both patients and the system. So as you can see, the attachment rates that were researched, we found that there were 700 unattached cancer survivors in the Vancouver coastal region at that time, and 3,000 unattached cancer survivors in the Fraser Health region. So the Fraser Health region is where I work, and the Vancouver coastal region is where Christina works. And the benefits to the patients and the system would be to improve adherence to surveillance recommendations, help to address and manage survivorship concerns, and help to relieve oncologists from managing primary care concerns. So the survivorship program responded to a need identified by the BC Ministry of Health and the NP4BC initiative, and confirming a need to provide primary care to unattached cancer survivors. The proposal to the Ministry of Health was successful, and the survivorship nurse practitioner role was initiated in February of 2013 in Vancouver with Christina's role. And in October 2013, another nurse practitioner and myself began practicing in the Fraser Valley, with a third beginning March 2015. I'm not sure if they've started yet. Not yet. So this slide shows about studies concerning nurse practitioner care versus physician care, and studies about the effectiveness of nurse practitioners working in primary care demonstrate that nurse practitioners can deliver high-quality, safe, and effective care to a variety of patient populations. For an example, here are two systematic reviews of literature related to measuring patient outcomes. The review conducted by Stanek Hutt et al. In 2013, which include random control trials and observational studies, found that patient outcomes related to blood pressure and blood glucose control were similar, whether care was provided by physicians or nurse practitioners. The review conducted by Horrocks et al. In 2002 also included random control trials and observational studies. The researchers found no significant difference in patient health outcomes between the patient groups treated by physicians or NPs. They also found that nurse practitioners undertook significantly more investigations. They had longer consultation times than the doctors, which makes sense because they're not fee-for-service. Studies demonstrated similar outcomes with limited sampling. So we need to know more about the practice and context and the outcomes of these two groups. Given this information, our local experience in BC with nurse practitioners working in a variety of primary care settings, we decided to further explore the development of the survivorship nurse practitioner roles. And we'll look at the evaluation of these roles later. What is a family nurse practitioner? Nurse practitioners have been practicing in BC since 2006, so not very long compared to Ontario, where they've been practicing a much longer time, and you have a much larger population of them. We're a relatively young profession in this province. We're located in acute and primary care, mostly acute actually, and have specialized in many areas such as heart failure clinics, pain clinics, acute renal, emergency, and orthopedics. Think about 25% of us are in primary care in the community. We're registered nurses with a master's level of education and have completed both written and clinical license exams. BC is the only province in Canada that requires the clinical exam as a prerequisite for licensing. And I'm actually glad we do that. I think it adds to our respect from our medical colleagues and certainly prepares you better for the role. Our credentialing allows us to provide care for patients and have independent patient practices. We are able to prescribe drugs, order lab tests, imaging, investigations, and refer to specialists. Nurse practitioners' practice is defined by legislation and around our scope of practice. We need physicians for the ordering of certain prescription drugs, including benzodiazepines, methadone, medicinal marijuana, and narcotics. The legislation around the prescription of narcotics has recently changed, and by the end of 2015, we will be able to provide narcotics after the completion of a certification program. Physicians are still responsible for the completion of the BC Palliative Care Benefits forms, advanced directives for the end of life, including do not resuscitate forms, and various assessments for disability funding and assessments for insurance claims. And these are all slowly changing, but it is slow. So Christina has several physicians working at our worksite to help ensure seamless care, but I do not. So I have to become quite creative about getting these forms completed and accessing prescriptions of drugs that I'm not allowed to prescribe. And this does impact my efficiency. What is a survivorship nurse practitioner? A survivorship nurse practitioner provides primary care to patients who have had an oncology diagnosis. They can be at their initial diagnosis or in active treatment or in remission or at the end of life and palliative. These patients see me for primary care needs such as hypertension, diabetes, pneumonia, sinus infections, or depression. The care I provide addresses those needs with an understanding of the oncology experience and what it means for the patient and their family. For example, a breast cancer survivor with a new onset sore back or shoulder may be worried about bone mets. And often the families and the partners will be more worried or equally worried, and they may encourage the person to come in. The next slide will look at my caseload. So this is my practice description in numbers. I have 132 patients who've had a cancer diagnosis. Some have been free of cancer for decades, others had a reoccurrence and are living with it as a chronic disease, and others have actively growing cancers that are immensely life-threatening and thus palliative. I have about, of these patients, they occupy about 17 tumor groups. The major tumor groups are 32% breast, 13% colorectal, 10% cervical, endometrial, and vaginal, 7% thyroid, 7% lymphoma, and 6% lung. So I don't think this is representative of the area that I work in or the population of the type of tumor group living there. I think it represents also the comfort of the oncologist who is doing the referring, and the oncologists from certain tumor groups are more comfortable than other tumor groups. While tumor groups vary, how they manifest varies with each cancer and each person. They share survivorship issues such as anxiety, depression, fatigue, fear of reoccurrence, and changes in self-esteem and body image. And they all share this, more or less. Each one varies. My caseload's predominantly adult and older adult, where the cancer may be superimposed by one or several chronic diseases. So a breast cancer survivor could have COPD, dyslipidemia, depression, or be hypothyroid. Thyroid cancers are typically in young, healthy women who are facing issues around starting families, parenting, and may be superimposed by an anxiety about reoccurrence, fatigue, and change in body image. 7% of my cancer survivors are survivors of childhood cancers. And these are a special and very complex group of adults because not only has their health been impacted by the cancer, but also by the cancer treatment. So, for example, a young woman who had brain cancer as a child now has memory and thought process changes, plus they have the effect of the radiation treatment that they had on their brain, and that can cause further damage. Aging of the brain is sped up because of that radiation, and she's more at risk for secondary tumors, both benign and malignant. Support is very good while they're children. But like many chronic diseases of childhood, the supports are very poor after turning 19, and typically they need financial, social, and housing assistance and I do spend a lot of time helping connect them with other agencies. Of my patients, 26 of them are family members, and the average age is 56. My youngest cancer survivor is 7. She was a survivor of a renal carcinoma from age 4. And my oldest cancer survivor is actually 93. I have a 92-year-old with a renal cancer who is palliative. And then I have a 93-year-old who's living with leukemia, indolent leukemia. She's still driving. And the gender makeup is 70% female and 30% male. And 51% have ongoing appointments with an oncologist. So I'll just compare this to Christina's practice, which is on the next slide. So you can see the regions that Christina draws on, so north and a little bit east of Vancouver. And she has 237 patients. I've put in blue, I've put the number of patients I have to compare to. So Christina has 237 patients who've had a cancer diagnosis versus my 132. And Christina's been in practice longer, so that makes sense. She has these patients make up 24 tumor groups versus my 17. And you can look at the comparison in the percentages. And again, I don't know if that represents a difference in the population of these tumor groups in each area versus who's doing the referring and who we have to see, because we do have very small practices still, although they're very busy. So Christina has 46% breast versus my 32%, 11% lymphoma versus my 7%, 6% colorectal versus my 13%, 6% prostate, and 10% cervical, endometrial, and vaginal. And I just want to comment on the cervical cancers that I've seen. So cervical cancer is common, but not when it's metastasized. Metastasized cervical cancer in this day and age is quite odd or unusual. I don't know if you've seen any, Christina. And so since I've been practicing, I've had 4 women who are about between the ages of 35 and 50 who've had metastatic cervical cancer. 3 of them have died. And it's quite shocking because we have Pap tests that can tell us when we have early stage cervical cancer and it's curable. And I think it's related to the marginalized population that I see in my practice. Before I came into this role, I was practicing in Richmond, which has a very high English second language population, and we do see women with cervical cancer in that community. But it was always, in my mind, it was always related to a woman who had come to Canada and was a new Canadian and didn't understand about Pap screening, or perhaps wasn't comfortable with the process of Pap screening, especially with a male physician. So for me to see these women who are not English second language, who were born in Canada, is quite shocking. So back to Christina's practice, she has 50 patients who are family members. So your total practice is 287, and I have 26 family members. The average age of Christina's practice is 51, and mine's slightly older at 56. And our gender breakup is very similar, for 70% female and 30% male. And in Christina's population, 80% of them have ongoing appointments with the oncologist. All right, and how do we get our referrals? So when we started these roles, we were put in place to see unattached cancer survivors. And has that mostly stayed the same for you, Christina, that you're seeing unattached patients? Okay. So most of our referrals were coming from oncologists, and the BC Cancer Agency staff can refer, the oncologist can refer, other healthcare professionals can refer, patients and family members can refer when they've heard about the program. I'm finding more and more that referrals are coming from other places rather than the oncologist. The oncologist might mention it to the family and they will make a decision to call the office. They just need the number. And I still have a core of oncologists who do refer with this form that they created, but probably 50% of my referrals are from other places now, so we see them coming from dietitian. I've had one from an ostomy nurse, home care, case management, even a housing project. And I'm finding that in my practice, even though we were created to see unattached patients, I'm seeing a certain population of attached patients who have GPs who won't go back. Now they've been diagnosed with the cancer, they've had their treatment, they will not go back to their family doctors. They're either going to walk-ins or because of emotional and personal difficulties with the physician. And I'm seeing a number of palliatives like that. How do Christina and I communicate with the cancer agency? So the cancer agency has a unique database, an electronic medical record, which the oncologists and other providers can dictate and have printed into this electronic medical record. Christina and I have read-only access to that, but it's a great resource for us to understand what kind of treatment somebody has had. Then when we have accepted, or they have accepted us, we'll send a letter to the oncologist to tell them that we've met them and that we will follow them for their primary care. And then we send fax to medical records to let them know that we are their primary care providers, that add our name to case, so that when an oncologist or another care provider pulls up their record at the cancer agency, they see our names and they know we're involved with them. And we communicate on a daily basis through emails, faxes, phone calls as needed. I tend to use faxes and emails most. And if I send a fax, it can be scanned into case, and then it's there and I can see that I did it. I don't have to remember that I actually did it. And I just want to say a note about the oncology support. My experience so far has been wonderful with the oncology group. They're very quick with their responses, very thorough with their answers. I might send one sentence email to an oncologist, I'll get 2 paragraphs back. And it's been an immensely enjoyable relationship. And I've texted for answers from my patient practice, like workup for Hep C's and partial treatments. I've asked the GP oncologists for various questions as well, and they've been wonderful as well. So now Christina's role was evaluated. My role hasn't been evaluated yet, but it will be. And when the role evaluation took place, there were 2 parts to it. There was a part about the implementation of the role, as well as patient satisfaction. So in the implementation evaluation, it was done 6 months after the start date, and it was done to identify and address concerns early on before anything was set. And there were interviews with key stakeholders, so the family nurse practitioner, primary care and oncology, the family physician and research director of the UBC Family Practice Center, where Christina works. That's where her practice is based. The Director of Clinical Operations of Systemic Therapy at the Cancer Agency, Medical Oncologist and Assistant Professor, UBC Family Division of Medical Oncology and Cancer Agency, a Medical Oncologist, and a Nurse Clinician of Oncology Long-Term Follow-Up at the BC Children's Hospital. And in the interviews, the questions that they wanted to know about were awareness of the role and understanding of the scope, benefits of the role, opportunities for improvement, and other comments. So the questions were asked, how did you first learn about the survivorship nurse practitioner? Stakeholders were not all aware that nurse practitioner was accepting patients. So what was done, they printed brochures, distributed press releases, and submitted articles to partner newsletters. I think that, in general, people are quite aware of our roles now within the cancer agency. Understanding the scope, the question was, do you feel that you have enough information about the survivorship nurse practitioner role to work effectively together? Stakeholders were not clear about the nurse practitioner scope of practice and how the role is different from a licensed practical nurse or an RN or a GP oncologist. And actually that's ongoing. just because I think that nurse practitioners are so new in BC. That's part of the problem. So what was done was an organized face-to-face meetings, more than one, Christina? Meetings, to explain the scope and answer the questions. And what came out of that is the nurse practitioner is a primary care provider with training related to post-treatment surveillance and monitoring. The role is not the same as a GP oncology, general practitioner in oncology, who also does acute management. The primary purpose of the Survivorship NP is to provide primary care. So asking about benefits, we asked, can you tell me what you think about are the two most significant strengths of this role as it has been implemented so far? Stakeholders identified various modes of communication between the nurse practitioner oncologist, communication via phone, email, and/or electronic medical record. And established guidelines for communication reporting were set, because it seemed like every oncologist had their preferred method of communication and got quite difficult. We wanted to learn from our experience, and we continue to implement additional survivorship nurse practitioner roles across BC. So the question was, is there anything about the survivorship NP role that you think could be tweaked, changed, or improved? So there was feedback obtained for that, and any other comments. So the interview resulted in three themes: awareness, role clarity, and communication. Now, the patient satisfaction survey involved a client satisfaction tool by Baron Bowers. And it was developed explicitly to measure client satisfaction with a nurse practitioner role model of care, and that's why it was chosen. It had confirmed validity and reliability. It had previously been used at a BC-based nurse practitioner clinic. It was easy to understand and easy to administer by mail. Based on previous research demonstrating that satisfaction is correlated with adherence to treatment, it was mailed to 92 patients. 61 completed the questionnaire for a 66% response rate. And this is the tool, and the Baron Bowers tool, and it assessed effective support, health information, decisional control, technical competencies. And then the Cancer Agency added the last two, correct, Christina? Then the Cancer Agency asked about nurse practitioner accessibility, overall satisfaction with care, and open-ended comments boxes for people who want to make other comments. So under effective support, how comfortable or supported or understood the patient felt was assessed. Under health information, did the patient feel that they were receiving enough of the right type of information to make competent health-related decisions and life choices? Under decisional support, did the patient feel empowered to make their own health-related decisions? And under technical competencies, did the patient feel that the nurse practitioner has the necessary knowledge and skill to address their health needs? As well, the accessibility being assessed was, is the NP accessible in a timely manner? How difficult was it to make appointments or travel to those appointments? And the overall satisfaction with care, with open-ended comments boxes for comments about the nurse practitioner care provided by the NP. So here you can see the results of that questionnaire. So 97% of the respondents were satisfied with the accessibility, and there were comments like, I did not have a family doctor prior to being referred and probably would not be receiving regular care if it were not for this program. And there were 15 similar comments from the feedback. Most comments focused on the positive way the nurse practitioner provided effective support. Oh, not for the next one, I'm sorry. So the next one, effective support, 97% of the respondents were satisfied with that. And comments like, she really listens on a professional yet somehow personal level that is both informative and comforting. There were 39 similar comments. 92% of the respondents were satisfied with the health information, and the comments included, she explains everything to me in a way that I can understand. 89% of the respondents were satisfied with decisional control, and one of the quotes was, we came up with a health plan for me. There were 7 similar comments on the feedback. Under technical competency, 96% of the patients were satisfied with technical competency. And an example of a quote was, "My medications were changed. I was confused when to take them. The nurse practitioner examined them all, got my electrolytes in order, and solved the problem." And under that feedback, there were 24 similar comments. So, future directions and next steps. So, some of the practice challenges that have come up are vacation coverage, and that is for both Christina and I, but more for me, who does not have a large body of colleagues working with me in the place I work with. When this position was designed for the Fraser Valley catchment area, it was put into a freestanding outpatient building that focused on primary care. And at that time, in the area where I'm working, there were 3 physicians and 5 nurse practitioners. And since that time, all the physicians have exited, and now we're down to 3 nurse practitioners. So vacation coverage is an issue. And Christina, it is for you as well, but you do have a body of physicians who are available. Pain management and opiates are an issue, especially for the palliative group. And for now, we're managing with accessing the doctors who are nearby. I use the pain and symptom management consult team a lot for my palliative clients, and we share them that way. When the palliative clients can no longer come into the cancer agency or come into my office, then I refer them to the pain management team in the community who deal with the home care patients. We have a very complex caseload. My practice has high numbers of palliative patients with multiple comorbidities. It's related to the demographics and the resources that are available in the catchment area. Surrey is a quickly growing population, and the resources cannot keep up with the demand. Recently, there was a redesign of the emergency at the Surrey Memorial Hospital, and that is the major hospital in the region. That's where I refer most of my patients. So they increased the bed capacity of emergency to 100 beds, and when they opened, the occupancy rate and attendance to emergency went up 30%. So there were 30% more visits. And like all hospitals everywhere, there's a problem with people moving out of the hospital. So it is a big problem. And raising awareness of the NP role, this is ongoing. This will be ongoing for years and years and years. I liken it to the issue that we had when midwives came into British Columbia about 30 years ago, which some people may not know about. But it was a huge battle, and it took a long time for the midwives to be accepted. But now they're part of the system, and they're being referred to. And I believe that will happen to us as well. I think that within the cancer agency, we're being recognized for the work we do, and we will continue to expand our roles to other centers. And the plan is actually to have one of us at each center, each one of the 6 centers. We continue to evaluate the impact of the role. My practice needs to be assessed, and it will be, and ongoing assessment for possible research related to the practice needs need to be explored. Outcomes associated with nurse practitioners in collaborative practice with general practitioners in a rural setting in Canada was a mixed method study done by Alison Roots and Marjorie McDonald. I believe it was in 2012, and it showed that to make the contributions of the nurse practitioner role more visible, the specific changes that occur as a result of implementing this role need to be identified, and the associated outcomes need to be recognized. So here are some of the questions that I have about the nurse practitioner role. Does the nurse practitioner role increase the primary care access for vulnerable groups? What is the impact of this access? Patients tell me that they feel heard. So I wonder, does this make a difference in their quality of life, and does it make a difference to their health outcomes? I've also noticed that there's a significant anxiety among this population, some more than others. So I think, you know, anxious people who are diagnosed with cancer and survive become anxious survivors. But I think that there are some people who become anxious during the process. So what helps the anxiety in this population, and does it help improve health outcomes? And we need to study the effect of the survivorship nurse practitioner on mortality and morbidity. And these are some of the survivorship primary care resources. So the Cancer Agency has just revamped their website, and there are great resources on this website for survivors, for healthcare providers. The Oncology Clinical Practice Guidelines and Protocols in BC are posted on the bcguidelines.ca website. These are created by the Ministry of Health and the Doctors of BC in collaboration, and there are clinical practice guidelines for following colorectal cancer, for following palliative. That's two examples. They're very well done. There's also a Family Practice Oncology Network, FPON, that's been created by the Cancer Agency to increase the knowledge base of family practice physicians in rural areas. And that includes monthly webinars that are done year-round except for the summer. And the library, the Cancer Agency Library, is a wonderful resource for both for patients and for healthcare providers. I find them very helpful to research things that I need to know about and get back to me. Family members and patients, as long as they have a Cancer Agency number, can phone and have things mailed to them if they're in a rural community. The Forward magazine is a magazine that was started in 2013, I believe, and comes out 4 times a year for survivors. And there's a Life After Cancer web pages for patients. And this is all fairly new, so I actually haven't had feedback on that yet. And that's it.